All right, good afternoon and welcome to our MedEd Grand Rounds today regarding QI event reporting. I'm Dr. Jessica Seaman. I'm the Academic Success Consultant for Creighton Alliance. And it is nice to be back in person whenever we can, so thank you for being here. We are broadcasting between St. Joe's and Valleywise to accommodate as many residents as possible. And we also are recording this session, so if somebody wasn't able to come or if you'd like to see it again, we will have it recorded for future use. But hopefully our technology is going to do its magic today, and we're not going to have any problems, but I can't make any promises. Just a couple housekeeping items at both sites, Valleywise and here. Please make sure that you sign in. We do not have QR codes set up right now, and so make sure you sign in either on the way in or on the way out. We just have paper sign-ins there. And then we also have box lunches that I can see some of you are already taking advantage of. So please enjoy your lunch, and if you'd like to take one on the way out, then you're welcome to do that. So just a quick introduction of both of our speakers. RN Alex Tayo is the Quality and Patient Safety Program Manager here at St. Joe's, and he will walk us through the event reporting system. And then over at Valleywise is Dr. Alexandra Hollingworth. She's a surgeon with Valleywise and Quality Improvement Officer with Creighton School of Medicine. She'll be showing us how to utilize the event reporting that Alex Tayo is going to show us and turn it into a QI report or a QI project. We're so happy to have the Alex show here today. We've got Alex here and Alex there. So I'm going to go ahead and turn the time over to Alex Tayo.
All right, good morning, everyone. My name is Alex Tayo. As Jessica was saying, I'm the Quality and Patient Safety Program Manager here, one of two. Also attending today is our Manager of Patient Safety Officer at this location, Bill Alcock. Just wanted to chat with you guys for a couple minutes about what we do, show you a little bit of the event reporting system, and at the end I'll do a little bit of a walkthrough so you can kind of see what it looks like in person. I'm just going to preclude this by saying if you have problems, please give us a call. We're happy to walk you through it. Sometimes it takes a little bit to get used to, but kind of like riding a bike. Once you put one or two in, it comes naturally. So go ahead and get started. So today we're going to show you how to do an actual event report, the types of events that you'll be reporting, and just kind of go over a little bit of handoff communication. Communication is one of the biggest challenges that I feel many health systems encounter, so really important to kind of go over that and see how we can help one another, help our patients, then just give you guys our names as well so you can get in touch with us in the future should you ever need to. All right, so this icon right here you guys will see on the computers. It's iBoss Event Reporting. You just double-click on that, and it will actually bring up the screen that I'll show you in a little bit, and it gives you access to the system, allowing you to create your reports. It's pretty easy to access at least. One thing to note, it only pulls up an Internet Explorer. That's a work in progress to get it over to Chrome, but if you're going to access it, make sure you're using Internet Explorer. When you enter an event report, just a couple of things. Please enter the medical record number. Sometimes we see reports with account numbers. That's fine, but we'll always switch them over. And no dashes if you could. The event description, just brief and factual. Stick to what happened. It will kind of go over some do's and don'ts in a couple of slides. The location. So there's an area where you can put where the patient is located. When we think about assigning location to an event, it's really more about who needs to be aware of the event. So if there's a question with, let's say there's an issue where you wrote an order and pharmacy didn't verify it properly, or it was an order that wasn't caught as being incorrectly ordered, you can assign that location to pharmacy. to actually follow up. So just kind of keep that in the back of your mind. You're welcome to assign it to whatever unit as well. When we go in on the back end and look at all these events, we can relocate it as needed, and so will the reviewing managers. Any witnesses that may have more information about it in case it needs further investigation, there's a specific field for that as well. When you're looking at your role, please fill out resident. It helps us because that actually also lets us look at medical education entered reports versus the reports that are entered throughout the hospital by other roles, so it's very helpful. And then whatever outcome you may have seen from the event, you can free text additional details in this area. What to report, anything unusual or unexpected. It doesn't necessarily mean something bad happened. It just means maybe something didn't happen that normally would. Any equipment concerns, we actually do FDA reporting here through MedSun, so it's really important. If you guys encounter any type of defective equipment or a malfunction, please let us know through an event report there. Any adverse outcomes, expected or disclosed treatment complications, any transfer to higher level of care. Again, that may not mean that something went wrong, but the event did happen. Any issues with communication, results discrepancies, or other patient care concerns. And it's really important, too, any near-miss events are huge. Near-miss events give us an opportunity to kind of take a look and see, glad we caught it this time, how can we make sure it won't happen in the future? So it's really important for us to be able to learn from as well. When in doubt, report it. Just we can go through, and if there's duplicates, it's not a big deal. It's always good to have more information than not enough. So I'll break this out in a little more detail, but there are a bunch of different locations associated with the system. It can be a little bit daunting, but just kind of scroll through. Sometimes things don't make exact sense on where they should be located, but we can always help you out if you have questions. Reporting serious events, so loss of limb, loss of function, definitely let us know. Bring risk into the fold so that we can kind of get involved and help with, help coach you guys through any conversations that may need to be had. That's typically done with an attending, but, we're happy to chat with you all too, just to kind of get a better understanding of what's going on. Anytime that there's significant patient dissatisfaction in an interaction and you feel like you need help to kind of mitigate that situation, you're welcome to get in touch with us as well. Your obvious other resources would be unit involvement, so charge nurses, unit managers, things of that nature. They're very helpful when we have complaints that are occurring on the unit in the moment. And if you have questions, please contact your program director, or you can contact any of us here. These are our extensions. The risk line is more of a general line. It's a voicemail, and then you have our direct desk extensions on here as well. We always encourage you to try multiple. You're welcome to leave a message, but one of us will hopefully be by our desk and in the office. You can also page risk. We have someone on call, one of the three of us, 24/7. So if it's a serious event that maybe happens in the middle of the night and something needs to be done or we need to be informed, you can page us as well. Things that the event reporting system is not. So what goes in here, it's not a substitute for what goes in the medical record. It is not a place to air grievances or have infighting or point blame. There are different avenues for that. We wouldn't want that to show up in an event report. And there's a separate system entirely for reporting employee injuries, so we don't need to put an event report in the IBOSS system for that type of activity. One thing to note as well, when you guys consult with us, it's great. We're happy to help, but it shouldn't be documented in the chart. You can just give us a call, and we're happy to kind of provide direction and assistance as we can. Just a couple of things about handoff that are pretty important. So just to give a little bit of a background, handoff is that transfer and acceptance of patient care and responsibility. It is a real-time process, and it's from one caregiver to another and a team to another team. We want to make sure that continuity of care is ensured because it helps us to keep our patients safe. If that information isn't accurately flowing to the right person or the right people, then that's where we can kind of open ourselves up to risk. We want to make sure that everything we're providing is as accurate as possible. And if you guys are kind of seeing developments in the patient's condition, definitely communicate those anticipated changes to the person that's following behind you or the nursing team. That way we can kind of prevent things from happening rather than reacting to changes. 80% estimated medical errors involve miscommunication during the handoff process. So that's a huge chunk. It really emphasizes how important it truly is. The majority of these avoidable events are really due to the lack of effective communication. The breakdowns in this communication are a leading root cause of sentinel events. These are actually Joint Commission and CMS reportable specific types of events. That sentinel is basically a never event. We never want to see this happen. It should not happen. So it's very important that we emphasize the communication aspect of our roles here. And then from a liability perspective, communication is a big contributor and a leading factor in liability claims. From the complaint and grievance side, I would say it's probably the single largest cause of complaints from patients is lack of communication between providers and/or providers and the patient. And sometimes just having a second conversation and re-educating the patients can mean the difference between a good or bad experience here in the hospital. Consequences of miscommunication, obviously, top one, patient family dissatisfaction and complaints, delay or inappropriate treatment, omissions of care, increased length of stay, avoidable readmissions, increased costs, and then liability exposures as well. At this point, anyone have any questions? I'm going to go ahead and go from here and kind of show you guys the event reporting system itself and put in like a fake event so you guys can get an idea for it. All right. Again, just so that you guys have our contact information as well, and you can locate us within the Google directory as well. And let me pull up the system here. Okay. So when you launch that icon on the desktop, this is what you're going to be faced with. Red fields indicate mandatory fields. A lot of times they won't even let you continue to something lower until you've filled them out. So if I come down here and try to do a location right away, it's going to tell me that you have to tell me when it happened before you can tell me where it happened. So my advice is just go from the top down. Put in your medical record number. You either have harm or no harm. That's something that when we actually look at all the events that are put into the system. So if it's something that needs to be changed, we can handle it. If you feel like there is harm associated with it or there could be, you're welcome to place that as a harm event as well. You put a brief description of whatever the event may be. Maybe the patient had a decompensation in their blood pressure and it required ICU transfer in order to start inotropes. I'm just going to put a little something in here, patient, so I can keep going through. Requiring transfer to ICU. First and last name of the patient, pretty self-explanatory. Patient type, inpatient, outpatient, non-patient. So this is important. So like if you have, spouse of patient fell on the way out of the patient room, obviously that's not a patient event. So you don't have to put it in as the patient. You can put it as a non-patient with their information as well. Allows us to go back in and actually take a look at the record if they were, for instance, taken to the ER for further treatment. We'll put today's date in. If you could put the time, it's very helpful actually for us because when we go back in and try to read through the chart and see the cascade of events, it gives us just a good starting point. Don't worry about it if you can't recall or it doesn't come to the forefront of your thought. So that you can get an idea here as far as what the locations are going to look like. You'll click the plus button next to St. Joseph's, and we have quite a few locations in the breakdown. Some of our units will actually start with the numbers in front. Other units like the ICU, you'll actually come down here rather than putting like 2T or looking for the room number. It's listed as an ICU. So just a little bit of learning back and forth and kind of getting used to the system. But it's once you kind of put in a few and see where things are, it's pretty easy to pick up. So let's say this happened on 7HLT. You double click on it and say OK. Now, if you're in here and it wasn't 7HLT, it was actually Tower 7, right? If I go down here and try to put in Tower 7, it's not going to let me because it says you can only do one location at a time. So you actually have to come in, double click on it to get rid of it, and then go back in and enter it. So just one extra step there so you guys don't get stuck. It's happened to me many times. Patient location and reporting location, those can be two different things as well. They're not mandatory fields. If you have the information, feel free. Attending and involved physicians, witnesses or other involved. If the doctor was notified or the involved physician, you have the notification and time there. The reporter role right down here, this is where you choose resident. Outcome of the event, and then if there's anything further that may be applicable to a certain event, sometimes like down here, the OR will use this field if maybe there's a lost needle or miscounted object. And that is really it. Once you finish, you'll just click save, and the report is submitted. And then it'll show up for us, and we'll take a look at it and go from there. Does anyone have any questions? This is pretty much the gist of the reporting system. Is there anything that wasn't clear or anything that we could answer as far as what our role is for you guys and how we can be of assistance? All right. That is everything from our end. Thank you guys for your time and attention. And as I said, if you have any questions at all, please feel free to reach out to any of us, and we'll be happy to help. Thank you.
Thank you so much, Alex. We're going to switch over to Valleywise. Oh.
Jessica? Can you hear me over there?
Yes, can you hear us?
Yes.
Okay, we can hear you. We're going to mute our side, and then you can get started.
Okay. Okay, so I'm going to start today by talking about some issues that we can use for event reporting to turn into a QI or patient safety, quality improvement or patient safety project, because all of you have to do that. To graduate, we have to check you off and you have to do a project, co-lead or lead. That's what the requirement is. Right now, we have a lot of people in groups, but by the end, we need you to be lead or co-lead with these projects. I just want to mention my partner, Dr. Ashwini Arjuna. She is overseas. She's been stuck there for over a month. She was instrumental in helping with everything with these QI projects and patient safety projects and for the grand rounds. I have no financial disclosures, and if I show you any of the instruments or tools that we use here, I have no connection with any of those. So today we'll just talk about how we can use these event reports and turn it into a project. We can use the IHI toolkits for this. And then what's the endpoint? What's the endpoint of these projects for you? So here's something that's been bothering me over the past couple of weeks. And that is something that happens in one of our rib plating cases. And I said to the resident, I said, don't let the screw fall into the chest cavity. There's a big intercostal tear and a big hole in the chest wall. So the resident laughed at me and then said, yes, ma'am. And I said, well, I know this has happened before in other places, and I know that it's been difficult to retrieve it. There are ways, but it might require another procedure. So when Alex had mentioned never events and things, we don't want this happening. So with these cases, we have some 3D recons where we take a look at the fractures and what is our approach to the surgery. And we have to measure here on the right, we have to measure how thick the bone is to decide on the screw that we're going to use. Here are the plates and small screws. So you can imagine some of these are 10 or 12 millimeters. These are really small in size. So it's very easy to lose these in the field, or they get knocked off of the drill bit. The proper technique for using this instrument is to first go in parallel under the scapula and then turn your instrument, turn the drill perpendicular so that you do not lose it. It does not come off if the magnet's working. Doesn't always happen like that. There's been several times I've looked on the field and there's a screw over here and I'm like, well, what's going on here? So that is something this is the perpendicular view. So what if this happens? The never event that Alex was talking about. What if we couldn't find one of the pieces of hardware and it was left in the chest? It would be smaller than this, but something we do not want to happen. Where do I start? What am I going to start with? So what I do is I start thinking about, and I haven't completed a project on this, and it was just something I'm thinking about. Go to the IHI toolkits, and then you can start filling that out. That's the best way for me as far as visually and tactile. So if you're a combination learner, it'll help you look at your project and with flow sheets. You don't have to use them, but they're really, really helpful if you're not familiar with doing these projects. And I'll reemphasize, all of you do have to do a quality improvement patient safety project to get checked off for graduation, co-lead or lead. So we do use the Plan, Do, Study, Act model for improvement. And this is the project charter is where I start in IHI. And all of you are required to do the module, so you should be familiar with this site. And there's a toolkit that you're going to use. An aim statement is one of the most important things to start with. And this is what you're trying to improve. What are you trying to accomplish? For me, I was trying to accomplish the hardware from not migrating anywhere, for basically the screws from migrating anywhere, to stay on the drill, for the nothing to be able to fall into the chest cavity. And I wanted 100% of that. So your aim statement should have dates and percentages. I want 100% accountability by January of 2022 of all of the hardware. And I don't want any migration of the screws off of the drill. So I have to pick, do I want to do retained foreign body, or do I want to do migration of the hardware? I still haven't decided. So the template that I started using with the charter, here's easy steps to fill out, and you really can't see it on the screen, but basically it's talking about asking you questions. What are you trying to accomplish? And this helps you kind of go through what you need to start thinking about as far as measuring. You have to bring about a change and start a process. And you have to think about something simple and measurable. A lot of you have great ideas, and I'm saying, I ask you, what are you going to measure? And you're like, I don't know. I don't know what I'm going to measure or how I'm going to measure it. Measure it pre and post change. So for me, it was going to be either the migration of the hardware, or it could be a retained foreign body. And I haven't had that for this, but it may have happened in the past. The easiest thing I could do right now is to make sure that the process of the residents using the drill, so they need education as far as how to use the drill and the proper technique to see how many of these screws are falling off of the instrument. I haven't filled out this template, but this is another template that brings me through the steps. And I go through these in the workshops for the surgery residents. Here are the two packets I usually have the surgery residents use. One is a quality improvement packet, and the other one is the patient safety. So depending on your project, you can mix and match in what you want to use, like the root cause analysis is going to be in the patient safety. And all of you have to be familiar with the root cause analysis, and that brings you through that whole process. If you have to do an M&M or present a case, whether you're internal medicine, emergency medicine, or surgery, this will be helpful for your M&M as well. This is the diagram, the diagram that I really like here, because it tells me what the issues are, who's involved, and the equipment involved, and my environment, like the culture. What's the culture where you work? Are you allowed to speak up? Are you able to say, hey, that's missing over here, or you dropped this, or that's important for the environment. Maybe there's too many people in the room. Maybe there's like 5 people scrubbed in on this case, and there's a lot of hardware, there's a lot of things out on the table, and there's no room, and people are bumping into each other when you're trying to use the drill. The people involved are the tech, the resident, circulator, and also the rep too, to help with any malfunction of the equipment, because the equipment is going to be the drill bits. Is the magnet strong enough on these bits? I don't know. Are they holding the screw on the drill? Sometimes the resident has never used a drill in their life, and this is the first time that they're ever using a drill, male or female, it doesn't matter. There are people who have never used a drill, and you're going into this surgery and you have no clue of what you're doing. So the education has to be there as far as utilizing this to prevent this from happening. You cannot assume that they know how to use this device. So the method of using this equipment, and the other thing would be the tear in the chest wall. We can repair the chest wall first to prevent anything from migrating. We could do that. But we like to utilize some of these tears to help reduce the fractures, right? We use these tears to kind of get under the bone, to kind of reduce it, and then plate it. So it's useful actually when you do actually have some of these tears from the trauma in a flail chest. My endpoint is going to be, the endpoint here is what's causing the retained screw in the thoracic cavity. As I mentioned before, the 5 whys of the root cause analysis, I don't have time to go through that today, but I do want to mention that it's in IHI, and if you do want to do a root cause analysis, this template brings you through the process. After you decide on what you're going to do, you have to come up with a process. The problem is that you first have to think about who's involved. I have to interview, observe. I want to observe the environment first. Why is resident not able to use this device and the hardware falls off? What is going on here? So observing, finding out who the stakeholders are, who cares about it, who are the big people who care. I'm going to show you a resident project, and it was done pretty fast because there were people involved higher up that really cared about it. So we got it done pretty quickly. So try to get people who care about this, stakeholders, the people involved, all the people who understand your workflow. You might not have an attending help you with some of the stuff because they don't understand your workflow. They might think they understand your workflow, but they might not know what's going on with orders and all that. So remember, when you're doing these projects, involve the people who are involved in this process on a daily basis. For me, it's the tech, and it's the resident, and it's the rep in the room, it's the circulator. Those are the people who are involved in this process. They're going to be counting the hardware at the end of the case. And as far as the process, the backup plan for me for the process would be involve the circulator and the scrub tech. We usually do instrument and needle count. We can do like a sponge count. We'll do a hardware count at the end of the case. How is the sponge count checklist? Okay, instrument count, hardware count. Have you accounted for every single screw in the that we had? Either it's on a plate or it's in the box. So we can utilize a checklist for this process. That's just one thing I can change, but I don't want to change too many things at one time. I want to change one thing and see if that helps. Remember that you need to know, you have to have percentages and numbers. You have to have your data before the change. You have to have the change and then your data after the change. Make it simple though. Don't make it too difficult. Trauma has a great registry, so you can pull numbers off of that and then make your change and then go from there. So I want to show you this project, and a lot of you probably don't know this, but we never had a hold function. Was anybody here when we did not have a hold function for the meds? Probably not. So Dr. Wong was responsible for this because of her QI project. What she did was realized that there was issues with medications not being given, medications being held in the wrong way at the wrong time. So she started a project to start a hold function in Epic. We never had the hold function. So she worked with whoever was involved with this process, which would be the residents, the IT, and the Epic champions. And she had a lot of support, so she was able to get this through. So you probably didn't know this, right? But she looked at all the issues that were happening when medications were not getting held when they shouldn't have been, or held at the wrong time, or nothing. Pharmacy was also involved. So she met with IT, Epic champions, the pharmacists, physicians, nurses, all the people involved in this process who understand the process. And they worked on a hold function in Epic. If you want to do an Epic project, it's hard. I mean, your project will be on the bottom of the list, but this was brought up higher on the list because of the importance and the data that she was able to show as far as errors. So she started in September of 2019. That was a new Epic workflow that was introduced. And she had gotten some data before it was started. And then she implemented this. This was her population. And then she was able to measure. So she had a lot of surgery patients. This is all on surgical patients, pre and post. And she narrowed it down to Lovenox. You don't want to do all of the medications. You don't want to do all of the different antibiotics. You want to do something very simple. Start out simple first. So she showed the issues with Lovenox, because we have a big problem with that on surgery. She had over 1,000 pre, and then she had 800, a little over 800 post. So here you can see the stats, and this is looking at it with a quality patient safety eyes. You're not really looking at this with research per se, but that would be your end product, would be maybe you'll get a research project out of it. But here you can see that the medication was held incorrectly 87% of the time before implementation, or held correctly, excuse me. And then after, it was 95%. It was not given properly 11% before implementation, and then 2.6 after. That's significant. So not only the no hold orders, and then held at the wrong time. So this is what she did. Now it's pretty simple. It was something that was very necessary. All of you are using it. I don't think there's probably anybody here that's not using this function. But this is an example of what she used. And one of these could be maybe if there was some bleeding because it wasn't held, and there was some bleeding in the OR, and they had to give transfusions and things like that. I mean, that could be an event, and maybe that was an event that was reported. But this is an example of how you can turn that around into a project. So she decided to use this as her presentation. She actually won the competition when she presented her work, and she turned it into research project as well. So once you go through this cycle, you can actually start doing it with other things. So you can redo your PDSA cycle again and again to include more things, maybe more medications, or maybe she could have done several other different aspects of why the medication errors are happening. And that was just one piece of it, this hold function. I want to go back to her aim statement. The aim statement was simplified here because of the slides, but when you have an aim statement, you really need to have percentages. Like I would put by January of 2020, January 1st, 2020, I would like we would have 80% decrease in Lovenox administration errors at Valleywide. It has to have a percentage by when, and then you can move on to the other templates that we utilized. And this was the simple hold function. So that was it for my part of the presentation. So if you have any questions, the other thing is when you're doing your projects, you can reach out to me either through the Valleywise email or Creighton University email, and I can help you with your project, how to get started. If you don't know how to get on IHI or you don't understand the process, but this is something that I'm here to help you with, and we all need to do it. So I'm here on this side of the campus to help you with this. So what are your questions?
So Alex, can you hear me?
Yes.
Okay, so Dr. Hollingworth, one of the questions that might come up is, can you share any of those type templates with residents? So, you know, the AIM page, the method page, that kind of stuff, in order to help guide them?
Yes. So I have shared it with the emergency medicine and psych, but how would you like me to distribute that?
I would love to get an email out to all the residents with both of these slide presentations, and I feel like maybe we could do the templates at the same time. Would that work?
Yeah.
If you could just email them to Jessica, just on that email thread that we had, and then I can get those out by the end of the week.
Okay. The most effective thing I've done for the surgery residents is get them together and work on these kits that are printed out. And we get together in a workshop and I help them through the templates. And it gives them the protected time to actually do this, because otherwise everybody's way too busy to be doing any of this usually. So that's where we've been the most successful. If that
doing it by program, like getting a whole program together, or just a smaller group of residents across programs?
I think by program would be easier.
Okay.
During their protected time.
All right.
And then
thank you for being willing to share, for sure. We'll get that out. And are there any questions here at the St. Joe's site for either Alex Tayo or Dr. Hollingworth? Okay, Dr. Hollingworth, we don't have any other questions here on this side.
Okay, thank you.
Thank you so much to both Alex Tayo and Dr. Hollingworth. We appreciate your time, and we appreciate the residents that were able to come, and we will get this information out to you via email with the slides and the templates. Thank you.